Good morning, everyone. Just on behalf of Dr. Iden, I'd like to just welcome our grand round speaker for today. So, Arjun Sharma, he's a current cardiology chief resident and will be joining us for interventional cardiology fellowship in a few months. And he's, as you've seen on the cath reports, there's a lot of stents maybe not going in sometimes. So he said maybe we should talk about that. And his topic is stentless solutions from a percutaneous coronary intervention standpoint. And I'll hand it over to Arjun.
Right. So thanks to everyone for coming and joining me this morning. I think I'll just jump right into it, just so we have lots of time for discussion at the end, because I think that'll be the most engaging for everyone. But today I'm just hoping to cover a few things. So ideally, a brief recap of PCI history, mostly focused on why we developed certain technologies, a little bit of an overview in terms of where we are now, and the kind of current stentless PCI technologies that we have, some information about where we might be going in the near future in terms of some upcoming technologies and some upcoming evidence, and then hopefully everyone will leave here today with a little bit of an understanding about why we should care about any of this, which I think is probably the most important when we review any new technology or kind of talk about new evidence. So I think we'll just start with a case. We have a 27-year-old female who presents to hospital with acute onset chest pain at rest. The chest pain eventually resolves without medical intervention, but she presents to the emergency department. She's got no past medical history, no home medications, but she does have a notable family history of premature coronary artery disease, especially in her mother's side. In the emergency department, she has an ECG and a point-of-care ultrasound that are relatively unremarkable, but at first troponin that's elevated at 355 and further elevated to almost 1700 on repeat. And in the absence of another etiology to explain all of these findings, she's admitted to the Heart Institute, treated medically for acute coronary syndrome with dual antiplatelet therapy and anticoagulation. And she does have an episode of recurrent chest pain shortly after admission that results in kind of expedited investigations. And the first investigation that she does have is a cardiac CT, which identifies what looks to be a severe stenosis in the LAD and non-obstructive plaque elsewhere. And so after that finding is kind of posted, an urgent invasive angiogram is arranged where we find this. And so you can see here that in the mid-LAD, after the takeoff of the first diagonal, there is a severe stenosis with a second additional lesion kind of after the takeoff of a large second diagonal. And I think many people in the audience are probably thinking 27-year-old female, acute coronary syndrome, is this spontaneous coronary artery dissection? And that was the thought here too, but the vessel was further interrogated with intravascular imaging, OCT in this case, which confirmed a thin cap fibroatheroma with adjacent thrombus, actually suggestive of not only atherosclerotic cardiovascular disease, but plaque rupture. Consistent with kind of a textbook and STEMI, so to speak. And before we talk about the intervention that should be done here, or putting in a stent or anything else, I'd just like to ask everyone to take a step back. And if we knew nothing about percutaneous coronary interventions and had to think about the perfect intervention for this patient from a percutaneous perspective, what would be the things that we would want that intervention to do? I mean, we would hope that it would relieve the stenosis and reestablish flow. I think that's the most important component of any intervention for an acute plaque rupture. We'd also like whatever intervention to provide some degree of support to the vessel to prevent against recoil, which I'll talk about in future slides. Ideally, leave minimal footprint in the vessel. I think it's a principle in all of medicine that we like putting in the least amount of prosthetic material, but certainly in the percutaneous coronary world, we seem very used to the idea of putting in a stent and leaving foreign material in. Ideally, whatever intervention we would do for this patient would have minimal risk of additional restenosis beyond the actual pathophysiology itself, and then really limit imposing limitations on the patient for future either percutaneous or surgical revascularization options. And finally, contribute a minimal amount of additional bleeding risk to the patient by virtue of our intervention, in avoiding an unnecessary or prolonged antithrombotic therapy. And not to belabor the point, but I think everyone knows that our kind of PCI world started with balloon angioplasty in the 70s and the 80s. And of course, the initial thought process was just relieving that acute coronary stenosis. Now we know that this didn't provide durable results, especially compared to kind of the numbers of target lesion revascularization and interventions for restenosis that we're used to in the modern era, where our restenosis rates for plain old balloon angioplasty or POBA were as high as 30 to 60%. And there was a combination of kind of long-term failure with proliferative remodeling, but also short-term failure with abrupt vessel closure that was related to either flow-limiting dissections or thrombosis or acute recoil of the vessel after ballooning. And so to kind of combat against a number of those things, but especially the abrupt vessel vessel closure, we moved into the bare metal stent era in the 1980s. And that reduced the restenosis rates kind of at 6 months to 20 to 40%. And a big advantage about bare metal stents compared to balloon only angioplasty was the ability of the struts to provide kind of or combat against the recoil and kind of tack up the vessel, so to speak. But we still had issues with proliferative remodeling, which we now kind of term part of in-stent restenosis, or ISR. And the thought process behind that really is that whenever we balloon and stent the artery, we cause endothelial injury, which leads to fibroblast proliferation, and then neointimal hyperplasia, or this overgrowth of the neointima, which is one of the two mechanisms that we know generates in-stent restenosis, and the other being accelerated neoatherosclerosis, or new formation of atheroma inside the stent related to chronic inflammation. But really, for the neointimal hyperplasia, we developed anti-proliferative agents that we could kind of attach to the stent to try and combat against that hyperplasia. And initially that was with paclitaxel, which is an anti-tubule agent, but eventually we moved into kind of mTOR inhibitors like sirolimus and sirolimus analogs that people will be familiar with if you ever look at what's actually in the drug-eluting stent that your patient gets, things like sotorolimus, everolimus, biolimus, etc. And in the early generation of drug-eluting stents, we saw that there was significant improvement in early in-stent restenosis, but there was a little bit of an increase in late thrombotic events, later than 1 year specifically. But as we iterated on further generations of drug-eluting stents, we found that with advancements in stent architecture, smaller stent struts, better polymer materials, and better anti-proliferative agents, we were able to kind of reduce those late thrombotic events. And that kind of brought us into the, more later drug-eluting stent era, where we were able to get those numbers of in-stent restenosis and revascularization in the first year down by quite a lot. And so as we move kind of into the 2000s, we were seeing rates in the first year of in-stent restenosis around 8%, and target lesion revascularization of the stented segment about 2 to 4% per year afterwards. And it was really those anti-proliferative agents that helped us fight against ISR and continue to improve and improve and improve, with occasional late events still occurring. But ultimately, we're here to talk about stentless solutions today. And so despite all of those advances in drug-eluting stents, there still must have been some reason that people wanted to pursue a stentless strategy. And the rationale behind that is a few things. But really the idea behind the initial kind of mode of stentless PCI, which we'll talk about today, bioresorbable scaffolds, was could we provide some sort of short-term support to the vessel, deliver those same anti-proliferative drugs to the vessel wall, but not leave anything behind long term. And the idea really of trying to avoid leaving things in the vessel wall long term comes from a few things. One is that we know that permanent foreign material in the lumen, especially non-endothelialized material, affects vasomotor tone, endothelial function, limits things like positive remodeling. And then if you stent across a bifurcation, permanently jails side branches, and depending on how much you stent, might further limit your revascularization options, either repeat stenting or bypass grafting down the line. And just to take a second and talk about coronary endothelial function, we know that the normal coronary endothelium plays a large role in managing vascular tone. And of course, all of our friends in the nuclear lab are well aware of how coronary blood flow can change with stress. And so the normal response of, the coronary tree is essentially to balance these forces of vasodilation and vasoconstriction, which allows you to increase your coronary blood flow when you want it. And the vasodilatory forces are nitric oxide, prostacyclins, balanced by the vasoconstrictors, which are endothelins primarily. But when you end up with coronary endothelial dysfunction, you end up with the state of pathologic vasoconstriction, inflammation, and thrombosis. And these are things that we can test for percutaneously. So when we do coronary function testing, coronary endothelial function is one part of a broad set of things that we test for, in part by giving acetylcholine to the vessel, where a normal functioning vessel should dilate, and a vessel with coronary endothelial dysfunction should abnormally constrict. And when we started studying this in the early 2000s, kind of at the end of the bare metal stent, early drug-eluting stent era, we found that patients who had coronary endothelial dysfunction did worse. And so this is a stratified cohort of patients with and without coronary disease. I think it's about 300 patients from a study in the early 2000s who just had serial angiograms at a single center. And every single patient had coronary endothelial function testing. And the line at the top shows event-free survival in patients who had normal vasodilatory responses to acetylcholine, and the line at the bottom shows patients who had abnormal vasoconstrictive responses. And again, while this wasn't perfectly matched to coronary disease, they showed a very dramatic difference in event-free survival over a 96-month period. And then when they went back and did statistical analysis to control for the presence of coronary disease, that relationship still held true. And so we know that whether you have obstructive, visually angiographic obstructive coronary disease or not, coronary endothelial dysfunction contributes to more events. And when we started studying patients who had bare metal stents put in the early bare metal stent era and doing that coronary endothelial function testing, it didn't seem to have a significant effect pre and post stenting, but the first generation drug-eluting stents did. We seem to see this increased rates of coronary endothelial dysfunction in the first 6 months and beyond after PCI, which, when we continued to follow those patients in observational cohorts, did lead to more major adverse cardiac events. And we also know now, as we're doing more and more testing and understanding, angina in patients with non-obstructive coronary arteries better, that coronary endothelial dysfunction is also prevalent in this population. And the hypothetical scenario of a patient coming in with anginal pain who has an obstructive lesion in, the mid-LAD, for example, who has PCI, who comes back in with ongoing angina, and you might send them back to the cath lab, their stent is still open, who still has symptoms. Coronary endothelial dysfunction, we're understanding, is playing a role in that population, or the ANOCA population. It's not the only explanation, but it is one of them. And so for all of these reasons, work was done to try and generate a solution that didn't leave a stent in long term. And that kind of brings us to the first kind of large-scale bioresorbable scaffold that hit the market, which was the Abbott Absorb. And the idea behind this, it looks a lot like a stent, but it's not made of metal. It was made of this polymer PLLA, or poly-L-lactic acid, that essentially in the vessel wall over time got metabolized to lactate, and then to carbon dioxide, and then to water. And that was all done by the Krebs cycle. And so they had this durable polymer backbone, which also eluted everolimus, so the same as many of the drug-eluting stents of the same era. And over time, in this 24 to 36-month period, the entire thing would be resorbed into the wall. Now, there were a few technical considerations with the bioresorbable scaffolds. So because they were made of polymer and not metal, they weren't radio opaque. So during angiography, you actually couldn't see the stent. And so to kind of combat that, they had these two little markers. Initially, they were platinum, and later we moved to other platinum-like metals that allowed you to see kind of where the stent was. And then there was no real change to dual antiplatelet therapy, because there was still something in the vessel for at least 2, if not 3 years, at least at the initial phases of when bioresorbable scaffolds hit the market. But the idea was that this might have been the perfect Goldilocks solution between the two, that we put something in the vessel that gave you support, especially radially, in the first 6 months, but that progressively got resorbed over time, and that the weight continues to decrease and decrease and decrease, and you lose more and more mass. And eventually by 24 to 36 months, everything is gone. And the hope was that, well, that might help us normalize endothelial function in these patients. It may free them up for additional interventions down the line, while still giving us the same benefits of drug-eluting stents in the first year to 2 years. And the early evidence suggested that that might be the case. There were small studies where they looked at coronary endothelial function at different time points as the bioresorbable scaffolds got kind of resorbed into the vessel. And that suggested, exactly as we hoped, that maybe vasodilatory function normalizes with time. It seemed to track alongside resorption of the scaffold. And then the feasibility study suggested it was safe and efficacious in patients initially. And then the first kind of randomized control trials, which was Absorb 3, at the 1-year outcome kind of point when those results were released, actually met non-inferiority by their pre-specified cutoff compared to the drug-eluting stents of the day, with the specific primary outcome of target lesion failure. And so this was that study, Absorb 3, published in 2015, 2,000 patients with a vessel diameter of about 2.65 millimeters. And again, 1-year target lesion failure was their primary outcome. The Science everolimus eluting stent was their comparator. And again, this was mostly a population of stable coronary disease. So some unstable angina, about 25% of the population, but most of them were stable angina. And you can see here, there's a slight excess of events in the scaffold line, which is the blue line up top, but they met their non-inferiority cutoff. And so because of that, they received FDA and Health Canada approval in July of 2016. And, as we do in the medical community, we got very excited. So this is a kind of snapshot of a headline in the Calgary Herald talking about surgical tools that dissolve. It's not totally accurate. It's percutaneous tool. But again, like lots of drama, people talking about and getting interviewed about the new technology and how exciting this is, how helpful it might be to patients. Hospitals were releasing press releases about how great the technology is, and so there was a lot of interest in starting to use this in selected cases. And so back to our case of our 27-year-old lady with the mid-LAD disease, she ended up having a bioresorbable stent implanted in the proximal LAD. This is just a still from the end of the procedure. You can see that there was that second lesion after the takeoff of the second diagonal that was left for medical therapy. And she was discharged home on aspirin and ticagrelor or dual antiplatelet therapy, had some risk factor modification for some dyslipidemia that she had. And initially she did well. She had a single episode of recurrent chest pain 3 months later, for which she had a SPECT that was normal. And actually ended up having quite a prolonged period of dual antiplatelet therapy. The rationale for that I'll get into in a moment. And then kind of to reevaluate her coronary anatomy and assess the need for any additional therapies, a cardiac CT was done 5 years post PCI. And so again, I mentioned earlier that part of the problem, or maybe not the problem, with bioresorbable scaffolds is they're not made of metal, so you can't see them during fluoroscopy, but that same kind of quality allows you to essentially not see them on a CT either. Now again, this is 5 years in, and so we would have expected the stent to fully resorb, and as you see kind of it's going back and forth on the CT, what you can see is two little areas of bright spots there, one there, and as we come back, another in a moment, and those are actually the leftover markers, and that's all you can see. There's no stent in the vessel there at all, and so if you're used to looking at a CT scan of a patient with a stent, the whole thing lights up like a Christmas tree, but you don't see that, and so this is kind of a proof of concept that the entire scaffold actually does get resorbed, and we've seen this on OCT imaging, intravascular imaging, and also on CT. That's a well understood kind of way to image these resorbable scaffolds. And the patient continues to do well as of the current day. And it would be nice to say that all the evidence bore out exactly all of these hopes and dreams, but unfortunately it didn't. And that's why we don't have the Absorb on the market today. So the longer term follow-up of the Absorb 2 study, which wasn't a randomized clinical trial, but essentially was more of an observational analysis that looked at hard clinical endpoints of vasomotor reactivity and late luminal loss, showed that at 3 years, the scaffold was inferior to drug-eluting stents. And so that whole hypothesis of, oh, well, the endothelial function gets better with resorbable scaffolds, that doesn't happen with stents, didn't hold true at 3 years. And then Absorb 3, which was more of a clinical trial looking at target lesion failure, at that 3-year outcome in October of 2017, we also saw that scaffolds were inferior to drug-eluting stents. And that was driven basically both by target vessel myocardial infarction and device thrombosis. And so after all that hope and promise of scaffolds, a big pause was put on kind of the widespread adoption. And there was a lot of discussion of what to do with this evidence at 3 years. And so this is a quote from the PI of several of the Absorb studies, kind of talking about what went wrong. And really the message behind this quote, I'll leave it up for you to read, was that it wasn't the tool's fault, it's that we were using it wrong. We were putting it in vessels that were too small. We weren't pre-dilating lesions enough. We weren't post-dilating lesions enough. We didn't understand how to use it. And all the studies that we've done so far that show loss after loss after loss, we just didn't know how to use it. So we'll study it again and maybe make a harder set of rules that tell us how to use it. And that was the origination of the Absorb 4 study, which I'll talk about in a moment, but the damage was kind of done. The FDA released a safety alert in March of 2017. Abbott halted their sales in September of 2017, but Absorb 4 had already been started. And so this was, to date, is the largest randomized clinical trial that we have from this original generation bioresorbable scaffold. And it was their 5-year outcomes with improved technique that they talked about in this trial. And so they included patients with stable ischemic heart disease or ACS with de novo coronary disease, excluding STEMI and high-risk and STEMI. The patients had to have slightly larger vessels than were previously studied in the older resorbable scaffold trial, so 2.5 to 3.75 millimeters. And then they were very clear about specifying how to implant the bioresorbable scaffold. So pre-dilatation was mandatory, post-dilatation was encouraged, and you had to use 12 months of dual antiplatelet therapy at a minimum. Looking at the demographics on the left, again, still a chronic coronary disease population. The vessels that were intervened upon had normal flow for the vast majority of cases. Not a lot of diabetes, but otherwise a fairly standard cardiology trial, mostly males and mostly in their 60s. And the hope was that, with better technique, we might see that the absorb is just as good as drug-eluting stents, and that wasn't the case either. So these are the outcomes of target lesion failure and device thrombosis on the left and the right. And you can see that the line at the top is the bioresorbable scaffold, and there was an excess of events no matter how you cut it. And so the whole bioresorbable scaffold story as we knew it at that time, we kind of put to bed. And so in the meantime, while we were doing all of these studies over and over again, we were still seeing huge advancements in drug-eluting stents. But I think the people who had a lot of hopes for bioresorbable scaffolds, did think about a lot of different reasons for the potential failure of scaffolds. One of them might be that the struts were too thick. We had seen that with drug-eluting stents, and I'll talk about this in a moment as well in more detail, that the smaller we made the struts, the better the outcomes seemed to be. And the bioresorbable scaffold, the absorbed, initially had a strut thickness of 150 or greater micrometers. And that really led to this delayed endothelialization and more exposed material, even though it's polymer and resorbable, in the vessel. That still led to increased device thrombosis. Then there were other technical considerations as well. It tended to fracture as you really post-dilated it. You weren't really able to expand the scaffold as much as we can expand a similar size stent to get good apposition to the vessel wall, and a lot of other technical reasons why it might have failed. But really, we were seeing huge advancements in drug-eluting stents in this time. So new drugs moving from paclitaxel to sirolimus and sirolimus analogs, better polymer coatings that released those drugs into the vessel wall, better stent platforms, and then, as I mentioned earlier, much, much smaller struts. And so when we compare kind of our first generation drug-eluting stents that had strut thicknesses of 130, 140, 150 micrometers to kind of the newest ultra thin strut stents that we have on the market today, which are just 60 micrometers, we're thinking about a stent in the current day that's less than half as thick as the stents from the initial generation. And that's led to this huge improvement in outcomes. So this is a really slightly modified figure from an excellent state-of-the-art review in JACC for in-stent restenosis, really just demonstrating how much improvement we've been able to achieve going from balloon angioplasty to bare metal stents to first generation drug-eluting stents to kind of current generation drug-eluting stents, bringing our 1-year failure rate down to around 3%. And so if you're a skeptic, you might look at all the evidence that we've talked about so far and go, why do we need to pursue stentless solutions in the first place when our outcomes are this good? And for many patients, that's true, especially when we talk about cost, which I'll elaborate on in a little bit. But ultimately, the problem with a stent-related solution is that in a certain subset of patients, that permanent result may lead to something undesirable. And so this is obviously an extreme case, but this is a case report of a patient with 67 stents. And so, they have multiple layers of stents in every coronary artery, in branch arteries, and in grafts, because they are a CABG patient as well. And, while this isn't most patients that we treat with drug-eluting stents, and it's not even, any patients that we treat, it's still going to be a subset of certain patients. And so really, we moved from trying to widely apply these stentless solutions across the board to everyone to thinking more about niche scenarios. And part of that kind of led to the creation of drug-eluting balloons, which is our second kind of stentless technology that we currently think about more in our current area of PCI. And so drug-eluting balloons essentially was a way for us to deliver those same antiproliferative drugs to the vessel wall without leaving anything in at all. So you can think about it just simply as a complete, duplication of the POVA strategy, but with the benefit of the antiproliferative drugs. And the way we're really able to achieve that is by coating the balloon in something that allows for the transfer of that drug to the vessel wall, usually facilitated over a prolonged balloon inflation of 30 to 60 seconds. And the initial studies looking at drug concentrations in the vessel wall after short balloon inflations like that, 30 to 60 seconds, suggested that there was drug activity in the vessel wall for weeks, if not months afterwards. So you didn't need to leave something in the vessel to have sustained drug effect over months. And so because of chemical reasons, so difficulty with getting sirolimus and sirolimus analogs actually onto balloons and transferring them to the vessel with an inflation, the initial drug-eluting balloons used paclitaxel, even though the stents at the time were mostly sirolimus and sirolimus analogs. But when we think about, what were our use cases for drug-eluting balloons in the early days, it was kind of a natural thing that we came to understand that drug-eluting balloons might be a good target for in-stent restenosis, especially initially in bare metal stents when you have a in-stent restenosis. We know that a drug-eluting stent has less ISR than a bare metal stent, and that's, of course, the drug. So if you have ISR in a bare metal stent, why not just use a balloon to apply the drug? And so when we initially studied, balloon-only angioplasty compared to angioplasty with a drug-eluting balloon, we found that it was superior for ISR. That was actually drug-eluting stents population rather than bare metal stents. And then when we studied it against repeat stent implantation, so a second layer of stent inside the first one, we found non-inferiority in a few of the early studies in the 2010s, late 2010s. And so, this is just a sub-selection of many studies that kind of prove these points, but drug-eluting balloons kind of found their way into the treatment algorithm for in-stent restenosis, but not quite yet de novo coronary disease. And so as we started to think more and more about, well, these seem to work in an in-stent restenosis population, could we just use them for the patient who's walking in with their first presentation of coronary disease ever who needs PCI? We started to think about, well, what were the subpopulations of that group who seemed to do poorly with stents? And it was really patients with complex lesions or bifurcations, patients who have long lesions, patients who have calcification, but especially patients who had small vessel disease. And these were patients that we know had very high rates of in-stent restenosis. When you put in a very small stent, it tends to have a lot of neonatal hypoplasia. And so it was small vessel de novo coronary disease where we first started using drug-eluting balloons to kind of intervene on de novo coronary arteries. And so the first trial, actually, Picolito 1, which was done with a very early drug-eluting balloon, the Dior drug-eluting balloon, actually found that it was an inferior to first-generation stents. But in retrospect, there were a lot of issues with that drug-eluting balloon. It wasn't very effective. The drug was not applied very homogeneously across the balloon. And so very rapidly, we ended up with additional newer generation drug-eluting balloons. And when we tested those against second-generation drug-eluting stents in those small vessels, we found a lot of wins. So non-inferiority for MACE, non-inferiority for percent stenosis in the first two trials. And then in Picolito 2, which was a trial, again, on just about 230 patients, and in small vessels again, we did actually find superiority, specifically for the endpoint of late lumen loss, which was just what percentage of the luminal size of the vessel do we lose over time. Now, we did follow those patients out for about 3 years. And while the study wasn't initially powered to determine differences in major adverse cardiac events, when they followed them out, to 36 months post-procedure, it seemed as though there was a signal towards less MACE events in those patients. And so, this was really a win that suggested that maybe drug-eluting balloons are reasonable for de novo coronary disease in small vessels. And as we've kind of demonstrated over and over again in this whole quest, the creep of additional indications continues to grow. And so from there we go, well, what about larger vessel sizes? Of course, we have the same benefits as in the smaller vessels, but we have a few additional things too. So think about intervening on a main branch of a circumflex or an LED or an RCA. In addition to all the things we talked about previous benefits, not leaving a stent in, et cetera, what about downstream grafting of a vessel? If you stent 60 millimeters in an LAD, taking that patient to bypass surgery and having them find an appropriate place in that LAD to sew a lima onto is difficult. But if you intervene with just a drug-eluting balloon, maybe that's feasible. And then in addition, in treating a bifurcation with a small side branch avoids jailing that side branch. And then, something that was new with drug-eluting balloons that we didn't see with bioresorbable scaffolds was this potential for ultra-short dual antiplatelet therapy. And so the first time we really studied drug-eluting balloons in larger coronary arteries was the first cage-free trial, which was published in 2024. It was 2,200 patients and essentially randomized patients to standard of care with a drug-eluting stent versus a drug-eluting balloon only strategy with pre-specified criteria to bail out and put in a stent anyway. And essentially, these were patients who had a median kind of device and vessel size of about 3 millimeters. So kind of a small, like moderate sort of sized vessel group. They had a bailout rate of 9.4% in the drug-eluting balloon group. And I think that's a really important thing to think about. So when they assign people to this intention to treat kind of strategy, almost 10% of patients ended up getting a stent anyway. And when they looked at all of their data for their specific primary endpoint of this device-oriented composite endpoint, which is a combination of cardiovascular death, target vessel MI, or target lesion revascularization, they didn't meet non-inferiority. And so this was, again, another kind of loss for the stentless PCI kind of cheerleaders. But at least trying to understand if these results were congruent with the information that we already had, if you break down the data into patients with vessels less than 3 millimeters and greater than 3 millimeters in the small vessel disease group, where we already kind of understood that drug-eluting balloons were a reasonable option, the results were very comparable. And so this was totally congruent with the information that we already had at the time, where we kind of just lost out in bigger vessels. And so because of all of the information we've talked about so far, really at this point had defined a bit of a rigid box for drug-eluting balloons that were they were very useful for in-stent restenosis. They were useful for treating coronary disease de novo in small arteries, but nothing else. And that really didn't change until recently at TCT last year. The Solution de novo trial came out. And again, you might go, this is the 60th trial of drug-eluting balloons, like we've lost over and over and over again. But their claim to difference here was that they had developed a new sirolimus-eluting balloon. And so this was different than the paclitaxel-eluting balloons that I had mentioned earlier. And the way that they achieved this was with a special phospholipid coating and these micro reservoirs that containing the drug, and the entire coating and the reservoirs just get kind of transferred to the vessel at the time of balloon inflation. And so that allowed them to deliver what they suggested was a better anti-proliferative agent to the wall, and perhaps that might improve things. And so they took a patient group of larger vessels, so 2 to 5 millimeters in terms of the reference vessel diameter, no limit on number of lesions, and they could present either in terms of chronic coronary syndromes or with stable NSTEMI or unstable angina, with antithrombotic therapy based on local practice and local guidelines, with a primary endpoint of target vessel failure, initially over a 5-year period, but they released their 1-year results at TCT last year, and that's what we have to look at. And what they saw was that they met non-inferiority. So the composite of cardiac death, target vessel MI, and clinical target vessel revascularization, they were all fairly similar. You can see there, if you kind of squint in that graph, there is a slight excess of events in the drug-eluting balloon arm, but they met their pre-specified non-inferiority criteria. And, it would be easy and simple to walk away from this and just say they're non-inferior, but like a lot of the other studies we've talked about today, I think it's worth taking a few extra moments just to look at a few of the details from the study. And so again, this was a randomized controlled trial, but obviously the operators, the interventional cardiologists, knew that a patient was randomized to the drug-eluting balloon arm at the beginning of their PCI. And you can see here that in the specialty balloon per lesion and the rotational atherectomy or intravascular lithotripsy per lesion, that about 30% of the patients in the drug-eluting balloon arm had some additional work done to that vessel that didn't happen quite as frequently in the stent arm, where the kind of combination of those percentages is just about 10%. So 30% of the time we used cutting, scoring balloons, lithotripsy, atherectomy, when the operators knew, okay, we were committing to a balloon-only strategy here. And I think that really speaks to, one, operator comfort with the idea of just ballooning disease and walking away without a stent, but also, what did we have to do to achieve this non-inferiority result? And the second thing that I'll draw your attention to at the bottom is provisional device use per patient. It's a bit of an awkward sentence, but what that means is 20% of the time, patients in the drug-eluting balloon arm had bailout stenting. So about a fifth of that arm ended up with a stent anyway. And so, yes, this was a large population, and it was the largest trial of drug-eluting balloons to date. It was in big vessels. We met non-inferiority, but it's non-inferiority at 1 year only. At what cost? Because I can guarantee you, although they didn't release this data, that the cost of the interventions in the drug-eluting balloon arm was far, far higher than the drug-eluting stent arm. And again, not totally applicable broadly to acute coronary syndromes, and certainly not to STEMI or high-risk NSTEMI, where we don't really think twice about putting a stent in. For a patient who has unstable angina versus a patient who has a STEMI, we know that it works well in both populations. And again, that 20% bailout rate is a real warning flag that this is not a strategy that's going to work well if you just apply it liberally across the entire population. So, a lot of people have different opinions on this trial, but the way I think about it is, in a very selected population with a lot of work done and potentially a lot more money spent, you might get comparable results to drug-eluting stents in the short term only. And that short-term piece is important because we've seen time and time again with previous stentless solutions that short-term results can look non-inferior, and then that doesn't really play out when we look at them at 3 years or 5 years. But one of the other more exciting things that drug-eluting balloons might offer us beyond just efficacy in preventing ischemic outcomes is short depth. And so this was looked at in the Cage-Free-2 trial, which was also published last year in 2025. And there were a number of other trials that also have looked at this and are looking at this that we'll review today. But essentially, they took about 2,000 patients, and all of them had acute coronary syndromes across 40 hospitals in China. They treated them all with drug-eluting balloon-only PCI, and then they randomized them to 12 months of aspirin and ticagrelor, or this stepwise de-escalation, where they just had 1 month of DAPT, 5 months of ticagrelor monotherapy, and then 6 months of aspirin. And that population had about 20% of patients who were high bleeding risk. Their mean vessel size was small to medium-ish at 2.72 millimeters. And what they found was that there was complete non-inferiority there. Like the curves, for the cumulative incidence of their outcomes, which was both MACE and bleeding, which is a bit dirty, but the combination of the two is captured here, showed that there was really no difference at 360 days, so 1 year. And then they had pre-specified that they were going to do a win ratio analysis if their non-inferiority was met. And there was actually a slight trend towards wins in the stepwise de-escalation. And so this relatively large study of all ACS patients, I think, did prove that short DAPT is feasible. And that is a big win for sure for drug-eluting balloons. And so kind of where do we go from here onwards, and what's happening now? As we kind of come into the late 2020s, which I feel like makes me feel very old, we have a few new technologies on the horizon. And so one is the kind of return of bioresorbable scaffolds. And so initially our polymer-based scaffolds, the first to absorb, we kind of reviewed that, but there are new polymer-based scaffolds that are on the market, but they're for peripheral arterial interventions. And so the Esprit BTK, which is below the knee, has been FDA approved actually in the US for peripheral arterial disease since April of 2024. And so we know that in larger arteries and in the periphery compared to kind of balloon only, that it seems like a reasonable alternative, at least the FDA thinks so. But from a coronary perspective, we're thinking more about non-polymer but magnesium-based bioresorbable scaffolds. And so the first kind of iteration of this was called the Magmaris, which is this magnesium alloy that instead of getting kind of degraded in the vessel by the Krebs cycle, actually just corrodes. And so that was initially studied in a few trials and then iterated upon by the same company to the current generation, which is called the FreeSolve, which Teleflex makes. And they've had CE certification for kind of this platform in Europe for a number of years. And the idea is that, well, it wasn't necessarily the concept of bioresorbable scaffolds that was the failure. It was maybe our technical limitations at the time. It was how thick those struts were, how long it took the scaffold to resorb. Remember, the absorb was 24 to 36 months. And so for the newest version, the FreeSolve, 99% of the scaffold is gone at 12 months. And in addition, the struts, of the scaffold are much thinner. So depending on the size of the device, anywhere from kind of 90 to 140 micrometers, so thinner than the absorb. And what the evidence that we have now that looks at that is kind of a feasibility study, so Biomag 1, which was published last year, and their 3-year cumulative target lesion failure in 116 patients who were low-risk ACS and chronic coronary syndromes was just 3.5%, which is fairly impressive, actually. And I think what most of us will be waiting for with the series of wins and losses and roller coaster of seeing early wins and late losses, it previously will be the full RCT, which is Biomag 2, that's currently recruiting in Europe, where they're randomizing the same population of patients to either the FreeSolve or the Xience everolimus-eluting stent, looking at target lesion failure at 12 months. And so that's kind of what's happening now with bioresorbable scaffolds. In terms of drug-eluting balloons, there's lots of incoming evidence to talk about. So the 5-year follow-up of Solution de Novo, I think, will be very interesting for many people because it's really the long-term data that we would like to have before we start applying this to our patients. But then there's a number of trials that will also look at drug-eluting balloons in high bleeding risk patients. How helpful is it to have shorter dual antiplatelet therapy? And so the DEB-HBR study I've left up there is kind of just repeating the same analysis in high bleeding risk patients, but the debate study is actually quite interesting to me. In a population entirely made up of high bleeding risk or patients who are already on oral anticoagulation, they're going to randomize patients to drug-eluting balloons or drug-eluting stents with very short dual antiplatelet therapy. So if they have an ACS, 1 month of dual antiplatelet therapy, and if they're an elective PCI coming in as an outpatient, just peri-procedure dual antiplatelet therapy. And so, if you're a patient coming in as an elective, case through the day unit, you might just have a day or two of dual antiplatelet therapy and go home on aspirin. That's the regimen that they're suggesting in this RCT. And certainly there are modified regimens if you're on an oral anticoagulant. And then there's a few other niche indications that will start to be explored in the coming years as we get more data. So larger coronary arteries, there's another large coronary artery trial coming in reverse, looking at an endpoint of MACE and BARC3 and 5 bleeding. And then Restore, which kind of builds off of the idea of, is PCI of vulnerable non-obstructive lesions a helpful thing for patients, which is a whole ground rounds talk of its own, looking at a population of ACS patients who have kind of standard of care PCI of the culprit lesion, who have a residual lesion that's moderate, but on intravascular imaging has vulnerable plaque characteristics, randomizing those patients to either standard of care, which is just medical care, versus DEB only PCI. And they'll be looking at target lesion failure at 24 months. And then finally, I think it would be remiss to talk about this and not actually talk about what's going on at the Heart Institute. We do have an upcoming drug-eluting balloon trial, so the PREVAIL global study, and we'll start enrolling patients here soon, I think. And there's two arms to this study. One is looking at two different drug-eluting balloons in a patient cohort presenting with in-stent restenosis, randomizing to either the agent drug-eluting balloon or the PREVAIL drug-eluting balloon, which I think is important. It's important for us to understand, two devices within the same generation, what the outcomes are like. And then in a second arm, in the de novo small vessel cohort, patients who have CAD, not ISR, but just de novo coronary disease, giving all of them drug-eluting balloon PCI and comparing their outcomes to a historical control of patients with similar device characteristics who had drug-eluting stents. And so in summary, I think, we've established with reasonable evidence that drug-eluting balloons are useful in small vessel PCI for de novo coronary disease. They're useful when you want to shorten dual antiplatelet therapy, and that there's a lot of new technologies on the horizon, both for drug-eluting balloons and bioresorbable scaffolds. But I think there needs to be a lot of caution placed when we evaluate how good that new data is in terms of assessing what is the real comparator, because it should always be our current standard of care drug-eluting stents, which we know are very, very good, and also understand that one technology to another, even in the same generation, we may not be able to extrapolate the results of one trial to an entire class of devices, because we know that between devices there have been significant differences. And so obviously this makes analyzing all of this data quite overwhelming if you don't really understand the background history of all of it. And so certainly because of that, I think our standards will have to be very high. We'll have to have good understanding of long-term benefit, not just one-year analyses, where we kind of jump the gun, so to speak, and start applying these to our patients without an understanding of the long-term outcomes. But at a bare minimum, I think we understand that with drug-eluting balloons in the current era, we do have a lot of niche use cases, and that with time, we may see these niche use cases expand. But at a bare minimum, the way that they currently help us is that they expand our toolkit in terms of doing PCI, and we still need to kind of meet that lofty goal of the right intervention for the right patient every time. And having additional stentless therapies does kind of aid us in doing that. But in terms of takeaways for the future, when we think about novel or expanding use cases or the indication creep for all of these devices, we always need to think about what our comparators are. Where is there room for growth in technology? Where are stents going in the future in the next 5 or 10 years? Can we make them even thinner than they currently are? And where might bioresorbable scaffolds or drug-eluting balloons go? And then also understand which benefits are evidence-based compared to which benefits are theoretical. So we've talked about the idea of sending a patient who had a resorbable scaffold to CABG down the line. We still don't have patient series where that has actually been done. If we've done it in pigs, then that was all I was able to find in our search of the literature. So there are some benefits of stentless PCI solutions that people will talk about that are still theoretical at the current time, but that's important to understand. And then finally, what is practical and fiscally responsible? So I think we all understand that working in the Canadian healthcare system, if we have two different options that are both equivalent, it is responsible for us to try and choose the thing that's least costly. And so a non-inferiority result, even taking into account all of the caveats that we've talked about and several of the trials we've reviewed today, we still need to understand how expensive things are. And to kind of give you some data on that, our current drug-eluting balloons are about 5 times as expensive as our standard of care stents. And our ultra-modern stents, which are also evidence supported for about 1 month of dual antiplatelet therapy, are still cheaper than drug-eluting balloons. Now, that may change in the future, but that is an important thing to consider as well. And with that, I'd like to thank Dr. So, Dr. Chong, and Dr. Ahmed for their guidance and advice and expertise in preparing this talk, and I'll take any questions or comments. Also, we can't hear anyone talking on Teams, so I think someone put a chat and we can go from there.
Great talk, Arjun. Very expansive and detailed. Does anyone have any questions for Arjun? There's a mic on the side if you have anything to specifically ask. I have a question for you, just in terms of, as you said, stent technologies have improved. So for high bleeding risk patients, for example, we have, the Onyx stent. How would that compare to something like a drug-eluting balloon in patients? Because you started the talk off about what's the ideal technology for a patient, but what are some vessel characteristics and perhaps you would choose a DB or a BVS over, say, um, a novel stent like the Onyx?
Yeah, I think it depends. And so, like looking at the Onyx set, which not everyone may be familiar with, but the Onyx One and the Onyx One Clear studies suggested that it was reasonable to choose 1 month of dual antiplatelet therapy for that stent specifically. That's the one that I was mentioning earlier, which is about $800 compared to our standard drug-eluting stents, which are about $160, $170. And certainly, I think it depends on your success of lesion preparation beforehand. And so I don't think currently we have good data that tells us that in a moderate sized lesion, it's a clear win to put in a drug eluting balloon and do a 1 month of dual antiplatelet therapy compared to putting in an Onyx and doing 1 month of dual antiplatelet therapy. I think the thing to consider will be as we move into the future, can we prove that even shorter dual antiplatelet therapy with a drug eluting balloon might be reasonable? And some of the new studies that are looking at ultra short DAP, so potentially a few days of dual antiplatelet therapy for a stable patient with, stable angina, PCI, that might be the time that we really see an edge towards that in really high bleeding risk patients. But at the current time, I still think it's hard to really build a use case in a medium-sized vessel for a drug-eluting balloon over, an Onyx or theoretically an Orsiro. No, just back yourself.
Or that's okay. And I think especially for younger people,
Yeah.
knowing that all here there's how we certainly absolutely.
Yeah, I think it's a really good question. And at the current time, I don't know that we have good evidence to be able to suggest to a patient that we're going to get better outcomes in the short or the medium term. I think the theoretical benefit is still in the long term. We don't have data to support that yet. And so it becomes difficult to tell a patient, I think we're going to give you a better outcome. I think the best you could say is that we may be able to develop a similar outcome, but at the same time, we do have to have this dual responsibility of giving the patient in that moment, a good outcome, but also understanding that if we don't kind of foster support for newer technologies, that we'll never be able to see the iterations of improvement that we, have seen with drug-eluting stents, for example. Like I think the thing that always strikes me is that if you go back and you look at the outcomes for bioresorbable scaffolds, which we review, look back on as a failure because we compared them to the same drug-eluting stents at the time. But if you take those outcomes and you compare them to bare metal stents, they actually look favorable in a lot of scenarios. And so it was maybe just at the wrong time that we saw large advances in drug-eluting stents, but maybe further iterations of bioresorbable scaffolds may allow us to get to a point where we eventually get to better outcomes compared to drug-eluting stents. One of the things I think about a lot is that stent thickness kind of piece. And so when I think about stent strut thickness, like obviously I'm not a bioengineer, but I can't imagine we can make drug-eluting stents that much thinner than 60 micrometers. Like when we think about the Orsiro, the like ultra thin drug-eluting stent on the market for people who aren't familiar with it, 60 is compared to 130, 140, 150 with our initial stents. I don't know how much thinner you can make those struts and still provide radial support to the vessel. And I'm not sure how much more advancement in the drug-eluting stent world we're going to have. Whereas I still think there's a lot of runway for bioresorbable scaffolds and drug-eluting balloons to kind of develop on their technology. And so maybe that's the angle. Maybe we might be able to promise you a comparable result, but the understanding is that, as we continue to iterate on this technology and understand it more, we may be able to develop future technologies that beat it. But that's a hard line to kind of, stand on when you're talking about consent. Thanks, Richard.
Just two questions from the chat. So if Dr. Reno would like to ask, uh, if for the trials of BVS or drug-coated balloons, did they have skewed patient populations? And if other risk factors like LP(a) or inflammation or CRP were considered in the analyses? Because we know those things will impact things like new atherosclerosis.
That's a great question. I don't totally know off the top of my head. There were additional trials that I just didn't have the time to review within the scope of this presentation that looked at other indications, but I think they've limited really to kind of core bread and butter population thus far, just because we still are in the early days. So to my knowledge, we don't have any data looking at kind of different risk factor profiles for some of those patients. And most of the trial recruitment is going to be very similar to like our, the population that we see in the day unit coming in for PCI or in the STEMI bay. So it is going to be a lot of males and, a decent proportion of people who are diabetic and smoking, and maybe less of the younger population who have, FH or high LP(a) or non-quantifiable risk factors for coronary disease, where they present in their 30s and 40s. But it's also frustrating that that's the potential population that might benefit from a resorbable scaffold. So we don't have that data yet, but maybe it's coming.
And a final question from Dr. Chan. Any compelling reasons to argue against drug-eluting stents for all, unless they're in a trial?
Yeah, I think that is a good question. And I think at this point, I think it's hard outside of the small vessel disease population, unless any of the interventionalists here had other thoughts. Like, I can't think of a compelling reason to say across the board in this population we should always be using, something other than a drug-eluting stent, except in the small vessel population. But again, we were nowhere with this information 10, 15 years ago, and only after studying it over and over again, including sometimes failing once, developing a new generation of technology and studying it again, did we get to the current point of identifying that drug-eluting balloons are reasonable to use in small vessels. And so maybe it's just more time and more technology.
Great. Thank you all for your attention. Great job, Arjun. Thanks for the great talk.